So for today, I'm going to start off with a case and then hopefully give you an idea of how I'm going to justify this peculiar title that I have today. Sorry. Okay. So I have no disclosures. My only general disclosure is that the quality of data for this particular topic is limited to case report and case series. And I don't think we are going to have any better data just because of the nature of the disease. So this is a 64-year-old male with a past medical history of aortic valve replacement for bicuspid aortic valve, history of sleep apnea, bipolar disorder, and obesity, who presents from the outpatient with new onset AKI. So he was a referral to the AKI clinic, needing to be seen urgently for new onset AKI, but looking at his labs, we felt it was more conducive to admit him for work. So he reported increased shortness of breath along with fatigue, chills, and dark tarry stools a few weeks prior. He only had a history of travel locally to Washington, D.C., but no out of the country travel. And his outpatient medications included warfarin, duloxetine, Abilify, and aspirin. So on his labs, I've read the pertinent findings. So his creatinine 6 months ago, which was 0.6, is up to 3.3 milligram per deciliter. His albumin is slightly low at 2.9. He has a low hemoglobin of 6.5. The rest of the labs look normal. And his UA shows a large amount of blood with some protein. And our fabulous renal fellow does a uromicroscopy, which shows dysmorphic RBCs with RBC CAS. At this point, he has blood cultures, which is negative. His HIV, Hep B, C, syphilis are all negative, and he has an echocardiogram, a transthoracic, which is normal, along with a TEE later on, which is normal. So he had a GN panel, given the fact that he has an active urinary sediment with AKI scent. And I hope this kind of helps you justify my title. So this particular patient had a GN panel, which came back as ANA, which is 1 in 640. He had a C anchor that was positive at 1 in 80. He had an anti-GBM antibody that was positive at 93, so normal being less than 19, 19. Cryoglobulins that were positive. So he had a type 2 cryo with polymerizing IgG kappa with an additional band in IgM lambda, as well as polyclonal IgA, so a type 2 mixed cryo. He also had C3, which was very low, and C4 that was low. And he had an SPEP, which showed 2 monoclonal protein bands. So given this finding, and he also had Bartonella serology done, which showed positivity for IgG for both beta Bartonella Hensley as well as Bartonella quintana, and IgM that was positive for Bartonella Hensley. So obviously with his renal findings, he went on to have a renal biopsy, which showed his light microscopy had some acute tubular injury, interstitial inflammation, mild tubulitis. His IF showed some positive mesangial staining for IgA, IgM, C3, kappa, and lambda, but he had no glomerular capillary linear staining. And that's important because of his anti-GBM. Now, his EM showed some dilated capillary loops with endothelial edema, with some mesangial expansion and smudgy electron deposits, electron densities. So taken together with this presentation, with his clinical features, he was diagnosed to have Bartonella infective endocarditis associated with glomerulonephritis. So going forward in the talk, I hope to explain some of the findings that is unique to culture-negative endocarditis, especially Bartonella, and the key features that make this entity unique. So I'm going to discuss the features that make Bartonella unique compared to other infectious causes of endocarditis-associated GN, explain the testing challenges in diagnosis of this condition, identify key findings in systemic and renal manifestations of Bartonella endocarditis, endocarditis-associated GN that differs from other infection causes of GN, and illustrate the management challenges that is faced in clinical practice. So as we all know, Bartonella species is the leading cause of blood culture negative infectious endocarditis. And overall, if you take all comers for endocarditis, the mortality still remains high at 25 to 30% at the end of 1 year. And Bartonella, being culture negative, has a higher incidence. Now, Bartonella is a vector-borne illness via fleas, lice, or sandflies, and animals are mainly the carriers of this infection. Now, Bartonella-associated infection, associated GN, with this multiple antibody positivity can closely mimic primary autoimmune glomerulonephritis, like an ANCA-associated vasculitis or lupus nephritis. But it has several distinguishing clinical, serological, and histopathological features that kind of helps us differentiate between the entities. And the frequent association with a high ANCA titer, especially PR3 specificity, makes it really a big diagnostic challenge. Now, as I mentioned, Bartonella are fastidious gram-negative intracellular bacteria, and they're transmitted by humans to humans by insect vectors. So Bartonella lives primarily in cat erythrocytes, and they get sucked up by the fleas that live on the cats and then excreted in the flea feces, which is then present on the cat's skin. Now, when the cat scratches itself and then scratches a human, that's when the transfer occurs into human beings that results in a Bartonella infection. The problem is that the detection by blood culture requires a very long incubation period of about 21 days and in a special environment. So it needs a culture that's 5% carbon dioxide in chocolate agar or a heart infusion media with 5% rabbit serum at 35 to 37. And this is the Bartonella bacteria growing on an agar culture. Of the Bartonella species, the most common ones that affect in humans is Bartonella hensleyi and Bartonella quintana. There are others like Bartonella bacilliformis, which also affect humans, but these are the primary ones that affect or cause glomerulonephritis associated with Bartonella. Now, detection of Bartonella is a challenge because it's hard to grow, and we mainly rely on serology by indirect fluorescent antibody assay. The problem is that the IFA is not species specific, and there's considerable cross-reactivity between Bartonella hensleyi and Bartonella quintana, along with other Bartonella species, and also with other organisms like Coxiella, or some of the rickettsial ones. Now, to counter this, there has been, we've used, or the tests have used specific recombinant antigen, like the 17K kilodalton ELISA-based enzyme that detects IgG antibody against Bartonella hensleyi. Now, this is what it would look like in a vero cell that's infected with Bartonella hensleyi. And a high IgG titer, so many papers say more than 1 in 800 is considered positive. The problem is that we know IgG just means a past infection, and we need IgM to diagnose acute infection. And IgM antibodies, sensitivity on IFA is very low as less than 10% in certain studies report. So that causes a problem because obviously it's then hard to detect if a patient has Bartonella infection. So other techniques that has been used to detect Bartonella is mainly molecular detection using PCR-based assays. And even in the PCR-based assays, you have to target specific genes like the GLTA or riboflavin synthase C in order to detect specific Bartonella species. So in a cohort of clinical specimens that was submitted in the University of Washington over a 15-year period, they did sequencing, PCR sequencing by different methods, and they found that the positivity rate has definitely improved in the last 10 years compared to in the previous years, along with improved technology. And the fixed tissue had a much lower yield of detecting Bartonella than tissue that was not fixed. So this is specifically important when you're sending cultures like tissue valve cultures, which may already be fixed in a media. Now, whether does matter if the PCR is done in blood versus liquid culture, and it really doesn't matter. The specificity is pretty high along with the positive predictive value. So the type of culture really does not matter if you are doing PCR. Now, as I mentioned, there are several species that cause infection in humans in terms of Bartonella species. But of the vectors or of the hosts, cats, dogs, horses, and macaques, which is a type of monkey, are the main ones that's being reported to cause human infections. And of the vectors that can transmit the Bartonella, fleas and lice are the primary ones, but it's also been found in ticks, bed bugs, and also spiders, apparently. Now, what about animal exposure in Bartonella-associated glomerulonephritis? So this is a case series, which is the largest one that I could find in the literature out of OSU. And they looked at about 72 prior publications for Bartonella-related glomerulonephritis. And out of the pooled analysis, they had about 89 cases of Bartonella-associated glomerulonephritis that was biopsy proven. And they compared this with 51 other culture proven bacterial endocarditis-associated GNs. And they found that 45% of patients in that cohort had a reported cat exposure. And 7% of that group had more than one animal exposure. But they did not have data for all the patients. So about 43% in that cohort did not have available data if they had any animal exposure. Now, the other question that this group addressed was, does the location of endocarditis clue into whether this could be pointing more towards Bartonella versus other endocarditis? And it seems like of the locations of endocarditis, the non-Bartonella associated GNs have a higher predilection for the right side of the heart, primarily tricuspid valve involvement compared to the Bartonella associated glomerulonephritis, which tend to favor the left side of the heart. So around 70 or almost 70 plus patients had the left side of heart affected or multiple valves involved compared to the other forms of endocarditis. Now, when they looked at how the confirmation of these organisms were done in this cohort, as you can see, 100% of patients in the non-Bartonella group had blood cultures that grew their organism, but only 4% grew an organism in the Bartonella group. And the detection of Bartonella was mainly by serology or PCR in most of these cases. The serology seems to be the initial screening test that the patients had, followed by confirmation with a PCR. In our particular patient, he had actually a free cell DNA sent for detecting Bartonella Hensley for confirmation. Now, the other problem is that routine gram staining does not pick up Bartonella because it has a very low carbohydrate level. And it needs special staining with Wharton starry stain in order to detect Bartonella on a tissue stain. Now, what are the renal parameters that differentiate or that stand out for Bartonella compared to other infection-associated GNs? So in this, I want to focus on the serology that has been reported with these two cohorts. So the blue is infection-associated GN due to other causes, and the orange is your Bartonella-associated causes of GN. So as you can see, there is a much higher incidence of ANCA positivity in the glomerulonephritis due to Bartonella. So 75% of the patients were positive, and they did not have ANCA testing for all the 89 patients. They only had results for about 69 patients out of the 89. And out of that, 75% were positive for PR3, and only one patient was positive for NPO in this cohort, and about 4 or 5 patients were positive for both NPO and PR3. Now, 39% of patients had cryopositivity, and 84% were positive for rheumatoid factor, compared to 52% in the other group. Now, all comers had hematuria and proteinuria, and both groups had low C3 and C4, but the low C3, C4 seemed to be more pronounced in the patients with Bartonella-associated GN compared to the other infection causes. What about renal pathology? So in renal, Bartonella endocarditis-associated GN has some subtle differences and some unique features that helps it to differentiate between other bacterial infection-associated GNs. So this is a slide from one of our other patients, courtesy of Dr. Zheng, who had Bartonella-associated infectious GN. And as you can see, this beautiful crescent in the light microscopy. Now, this tubule here shows an RBC cast, and you can see some nonspecific inflammatory cells in the interstitium. So the most common finding in Bartonella-associated infectious endocarditis is a crescentic glomerulonephritis with or without mesangial proliferation and endocapillary proliferation. In the IF for this particular patient, they had positivity for C3, very faint positivity for IgA, but also had IgM and C1q positivity, along with lambda and kappa. Now, one thing that Bartonella behaves like is a full house. So normally we relate a full house to lupus nephritis, and this is the other condition that can give you a full house, including the C1q positive. Now, presence of IgA is less common in Bartonella compared to the other GNs. Now, on electron microscopy, usually the deposits are mesangial or subendothelial or epithelial, but mesangial deposits are more common than your classic subepithelial deposits. Now, in this particular patient that we have, as you can see my arrow, he had a beautiful subepithelial hump on his electron microscopy. So in this cohort of patients, the 89 patients that they looked at renal pathology data, what they found was the key main findings, as I mentioned, was there was a presence of a crescentic GN, 83% in the Bartonella-associated group compared to other causes of infection, which was close to being significant, as well as presence of necrotizing lesions were more in the Bartonella group compared to the other group. IgA positivity seemed to be more prevalent, so 73% in the non-Bartonella group compared to only 35% in the Bartonella group. And IgM positivity, though, seemed to be more predominant in the Bartonella group. Now, C1q, which is an initiator of the classic complement pathway, seemed to be more prevalent in the Bartonella group endocarditis of close to 70%. And they excluded all the trace cases, so cases that were strongly positive. And this was statistically significant when compared to cases with non-Bartonella endocarditis. Now, this is another cohort that was published this year where the authors took renal pathology biopsy specimens from databases along the West Coast, so Cedars-Sinai, Cleveland Clinic, Oregon University, and they looked at renal pathology confirmed infection endocarditis GN cases from 2015 to 2023. And this series kind of mirrors the previous series in terms of their findings that were more unique to Bartonella, like the cryopositivity, which was about 45%. The other aspect I want to bring to attention is the fact that 55% of these cases actually received some form of, were suspected to have an autoimmune disease and were treated with immunosuppressive medications in spite of being infectious before they were discovered to have infection-associated GM. The strong C1q and strong IgM was also another feature that was duplicated in this study. Now, what about the association with end-stage renal kidney disease and endocarditis? So in this cohort of patients, they looked at what factors had a poorer prognosis for renal recovery in all comers, so all causes of endocarditis-associated GN. And they found that female sex, presence of nephrotic syndrome, the use of immunosuppression, along with diabetic glomerular sclerosis was some of the features that had a much higher risk of ESRD compared to some of the other factors. Now, when they split the data for Bartonella versus non-Bartonella GNs, the female sex, serum creatinine, nephrotic syndrome, and the C1q staining were the prominent features that predicted a poorer prognosis for our Bartonella group compared to the other infection group, in which immunosuppression use had the highest poor prognosis prediction. So I want to take a look at the ANCA positivity for infection endocarditis because there's numerous case reports along with case series that have shown that ANCA positivity tend to occur in infection endocarditis. Now, for some reason, they seem to be more common in men in 80% of patients compared to women. And I really don't know the answer to that. Now, it has been reported in both Bartonella as well as other infective endocarditis. Now, in infective endocarditis, the prevalence of the ANCA positivity detected by immunofluorescence or indirect immunofluorescence seemed to be similar to the prevalence of other autoantibodies, like the ANA or the rheumatoid factor. And this may just be because of the total IgG level increase with increased B cell stimulation, but may not be specific for the disease. So in order to look at why Bartonella could be causing this kind of ANCA positivity, I want to go over some of the features that may be similar in the two by using ANCA as an example to talk about Bartonella. So just as a recap for our fellows and our residents on this call, now when we think about ANCA assays, we think about two different tests. Right, so one is a screening test, so that is your indirect immunofluorescence. And as a reminder, how it's done is that the neutrophils are fixed fixed with ethanol on a slide, a glass slide. This is then coated with the patient's test serum, which, if it contains ANCA, will bind to the target antigen. The slide is then washed with a second and a second anti-human antibody is then applied, which is fluorescent tagged, and this is read under a microscope to detect the pattern. So if it is cytoplasmic, we call it C ANCA. If it's perinuclear, we call it P ANCA. Now, your confirmatory test is the ELISA, and this is both a quantitative as well as qualitative test, and you're looking to identify whether it's a PR3 or an MPO. And in this, you have a special plate that has the target protein in different wells. So that is purified PR3, purified MPO in different wells. And then you apply the patient's serum to the plate. And then if the patient's serum has PR3 antibody, it's going to bind to the PR3 antigen. And then you apply an enzyme-labeled antibody and a substrate, which then detects a color change that you measure and you quantify and report a value for the ANCA. Now, a lot of this testing that we do now is bead-based multiplex technology. So there's multiple beads with multiple antigen, and the patient serum gets treated to those like sending a full GN panel. So what are some of the features of ANCA that might be common to Bartonella that kind of helps explain the ANCA positivity in this scenario? So one of the theories for ANCA positivity, so ANCA binding leads to upregulation of genes expressing pro-inflammatory mediators. And this favors an adhesion and migration of neutrophils throughout the endothelium. So in this first hypothesis, it states that the PR3 ANCA that's generated due to auto-antigen complementarity begins with the production of an antisense strand that's complementary to the PR3. And then this, or the bacteria which have a sequence which is homologous to the PR3 antisense DNA. Now, this leads to an immune response that's elicited by the production of antibodies against the PR3. And then this goes back and attacks the PR3 and causes self-damage. So that's the complementary peptide, which could be potentially a mechanism in Bartonella too, where it may be complementary to the PR3. Another possibility is molecular mimicry. So like other species like Staphylococcus colonizing the nasal passage, or intestinal infection with Entamoeba histolica, molecular mimicry is in which the foreign antigens induce an antibody production, and again, which has an affinity to self-antigens. So this is postulated to be another mechanism by which possibly Bartonella can cause production of ANCA in Bartonella, and other infections can cause production of ANCA in endocarditis-associated GE. Another possibility is an impaired apoptosis of neutrophils that leads to increased antigenic exposure. So when you have neutrophils that are damaged, they get cleared away by our immune system. But in certain cases, there's a delay in this clearance, which increases the antigenic exposure, leading to translocation of the neutrophil antigens into the bloodstream, thereby producing, again, antibodies against ANCA. Now, we know in data that's in animal models that beta-quintana tends to delay apoptosis. So that might be a possible mechanism in Bartonella leading to ANCA production. And finally, there can also be an extracellular release of target antigens, which may occur within the environment of neutrophil extracellular traps or nets. And this can be processed by antigen-presenting cells and then develop autoimmunity, leading to, again, self-antibodies. So as I mentioned, Bartonella lipopolysaccharide has shown in human culture media to actually delay apoptosis. So in this particular diagram, if you look at the green, which is the control panel, that shows the apoptosis of cells induced. So there's a sharp peak followed by a sharp decline. Whereas these are the cells that, this is the beta-quintana lipopolysaccharide in human polymorphonucleosides. And you can see that there is a slowing of apoptosis in this group compared to the control group. Now, what are the other features that is unique that could, again, add to the Bartonella infective pattern? So usually when you have an infection, there's pathogen-associated molecules that are called your PAMs or DAMs that are recognized by your innate immune system. And this leads to upregulation of your toll-like receptors, which then help fight infection. Now, one of the features of Bartonella lipopolysaccharide is that it only weakly recognizes the toll receptors and does not evoke a toll receptor-like activation when you compare it with lipopolysaccharide from other endotoxin-producing infections like Staphylococcus. Now, beta-quintana also causes overproduction of anti-inflammatory interleukins like interleukin-10, and it antagonizes the pro-inflammatory factors like toll-like receptors. So it seemed to set a tone for more of a chronic inflammatory process. So this causes it to maintain inflammatory activity for a much longer time than with conventional bacteria that produces lipopolysaccharide and leads to a chronic inflammation. Now, what about other molecular mechanisms that are specific for Bartonella? So Bartonella found in human endocarditis also has specific tropism for vascular endothelial cells, and it enhances vascular neoproliferation either by induction of endothelial cell proliferation, inhibition of endothelial cell apoptosis, or by production of vascular endothelial growth factors by the infected macrophages. It releases chemoattractant interleukin-8 that can recruit more polymorphonucleosides and macrophages to the site of infection. And then this delay in this polymorphonuclear cells apoptosis makes the PR3 remain in contact with the host immune system for a much longer period of time, which could explain why there's production of anti-PR3 antibody. So, in my opinion, why does Bartonella trigger more autoantibodies? I think it's a combination of all these factors. The fact that it produces a low potency lipopolysaccharide. For example, Bartonella has not been shown to cause a septic shock-like syndrome. It's more of a chronic infection. Again, and with this delayed apoptosis, with the upregulation of interleukin-10, and the non-triggering of the other systems, our immune systems, our protective immune systems, gives it an advantage of producing a very chronic, prolonged infection leading to the autoimmunity and antibody production. Now, common features of both ANCA vasculitis and Bartonella endocarditis is that they are chronic diseases involving endothelial cells. And two, they both have a high prevalence of anti-PR3 antibody positivity. And, the ANCA positivity may reflect antigenic stimulation by the as we mentioned, in the neutrophilic enzymes released within the vegetation, or whether it's a generalized body response by a non-specific hyperhumoral response, it's not clear. Now, you might ask if the ANCA positivity that we see is a true positivity versus is it a cross-reactivity just by the assay? So in our patient, for example, when we did the ELISA, the ANCA titers for PR3 and C-ANCA was negative. But in the patient that I showed you the biopsy specimen of, the actual ANCA titers were high. So normal being under 20, the titers for that particular patient was in the 70s. Now, this was a case report where the authors actually followed PR3 ANCA levels from the time of diagnosis to when the Bartonella positivity was detected and the antibiotics were changed, and to at the end of 1 year. And they showed that there was a resolution of the ANCA titers with just treatment for Bartonella enterocolitis. Now, what about Bartonella and anti-GBM? Now, as you recall, anti-GBM disease is caused by anti-GBM antibodies or autoantibodies against epitopes of the alpha-3 chain of the type 4 collagen. Now, anti-GBM immunoassays are considered really highly specific and sensitive. So the thought of non-pathogenic anti-GBM positivity is thought to be much rare. So in our case, for example, the patient had an anti-GBM level of 93, where the normal was under 20. So it seemed like it had a quantitative positivity. But the thought is that the false positivity may be, again, a reactivity to other chains of type 4 collagen, as in the case, possibly Bartonella causing that kind of reaction. Now, a proposed mechanism as to the false positivity, whether it is a false positivity versus true, is whether there is a molecular mimicry, so Bartonella antigen sharing structural similarity with epitopes on type 4 collagen, or the endothelial injury caused by the Bartonella exposes the basement membrane antigens, which again then trigger autoantibody formation. And it's not completely clear as to what's the clear mechanism. Now, what about Bartonella and cryoglobulinemia? Now, cryoglobulinemia associated NPGN pattern on kidney biopsy has been reported in the setting of Bartonella. Both mixed type of cryoglobulinemia, type 1 and type 2. So type which has been associated with chronic inflammatory states, has been seen. And again, the potential mechanism is that chronic Bartonella infection results in a polyclonal B cell activation that results in hypergammaglobulinemia, which potentially triggers autoimmunity, including cryoglobulin production. Now, in one of the, it's thought that maybe the antibody generation is like an early host defense, but because the infection is so long and prolonged, this is what triggers the production of the cryoglobulins. Now, what about the abnormal monoclonal protein? So this was a cohort of 4 patients out of OSU, where they found that all the patients that they examined had IgG lambda clone that was detected on serum electrophoresis. Now, none of these patients on the kidney biopsy had a monoclonality of either lambda or kappa. And as you can recall, in our patient too, the patient had 2 monoclonal bands detected on SPEP, but on IFE, the clones were not clear. So the thought process is that, again, this is likely a dysregulated immune response due to the underlying Bartonella infection and not really a true monoclonality that's seen. So looking at the diagnostic algorithm, so I've given you a lot of features that is specific for Bartonella. And the problem is to try and recognize which patients that you want to warrant testing. Because the testing, as you know, takes time, and it usually takes about a week for any of the serology to come back for Bartonella. So if you have a patient that has a generalized illness that is suggestive of a subacute presentation with splenomegaly, anemia, weight loss, and with an AKI features suggestive of a GN, then obviously ask for Bartonella risk factors like cat exposure, previous valvular heart disease, homelessness, alcohol abuse, etc. And you want to consider serologies at plus or minus PCR testing, but remember that PCR also has a very low positivity in the blood sample compared to the tissue sample. And you can sometimes see only up to 50% positivity. Now, renal biopsy, the features that I mentioned, as in having a full house with a crescentic GN, and having mesangial deposits or not the typical deposits that you see with an infection-associated GN can be a triggering factor. And the absence of pulmonary features are also a strong one to consider thinking of a Bartonella. For treatment regimens, usually doxycycline, 100 milligram BID is used for 4 weeks along with gentamicin for 2 weeks. And that's if you can remove the tissue or replace a valve or clear the infection effectively. Other combinations that you can use is ampicillin or a cephalosporin in combination with an aminoglycoside. So coming back to our patient, now I remember I told you he had an echocardiogram as well as a TEE and a TTE, which was negative. So the question was, where is his focus of infection? And the credit for this goes to our Dr. Shah, who was the medicine attending on this case while the patient was admitted. And he ended up having a PET CT, which detected his endograft that was used for his aortic, for his aorta during his time of his valve replacement that lit up on PET that showed where the focus of infection was. So what I did not know was that the guidelines for infective endocarditis Duke's criteria changed in 2023 to include PET scan for, especially in the diagnosis of prosthetic valve endocarditis for those patients who fit the criteria for possible endocarditis, not the definite criteria. So in this large meta-analysis published looking at PET CT use in prosthetic valve endocarditis, they found that the sensitivity and specificity of patients was pretty high with the PET of 85%, both sensitive and specific. And this was in about 537 patients who had possible prosthetic valve endocarditis. Now, it's important to remember that the sensitivity for PET is much higher with prosthetic valve endocarditis and cardiac devices rather than for native valve endocarditis. So back to our patient. Our patient was treated with doxycycline, 100 milligram BID. Now, he was thought to not be a surgical candidate to have that graft in his aorta changed as per cardiothoracic surgery. So the plan is to treat him indefinitely for a Bartonella with doxycycline. He also received rifampin, 300 milligram BID for 6 weeks, and did not get aminoglycoside due to his AKI. So his creatinine post from admission to the time of discharge, last seen in clinic, his creatinine was down to 1.3 milligram per deciliter. My take-home thoughts for, with regards to this particular condition is that Bartonella infection-related GN has difficulty in detection and really needs a high index of suspicion for diagnosis. Now, the numerous autoantibody activation makes it challenging because it can result in several management errors. As you saw in that series, 50% ended up getting immunosuppression because of the delayed diagnosis. And choosing the right type of test can help with earlier diagnosis compared to a delayed diagnosis. with that, I'm happy to take any questions or comments.
Thank you very much, Dr. Parmod. That was an excellent presentation, starting with a case that you have had, going deep into the whole literature. Thank you very much. I don't know if there are people that have questions. One question I had is based on actually one of the studies that you showed, that the PR3 that they had was more of a cross-reactivity rather than true elevation of PR3. Did we check for this patient or?
So this patient actually was cross-reactivity because the PR3 and MPO was negative when done by ELISA. But in the patient that I showed you the biopsy of, it actually was positive on an ELISA. So it looks like both are possible with the ANCA, that you see cases where there's cross-reactivity, but you also see cases where there's true ANCA detection in the blood.
And then the question would be, what do you do with it if after 1 year the Bartonella is gone, but that one is positive?
So the thought is that when you treat the Bartonella, you should be clearing the ANCA effectively. There is some mention in some of the case reports that maybe if the biopsy is, or if the clinical response is not appropriate, to consider adding immunosuppressive agents like steroids for management. Obviously, with very little data, I can't really recommend that. That's something that's case-to-case basis. That being said, one of the other cases that I had, not these two, but that we ended up giving rituximab because we thought the patient had cryoglobulin, as that patient's cryo and ANCA were positive and had crescentic GN, did end up coming off dialysis and remained stable a couple of years post. So anecdotally, thankfully, nothing happened to him, but
perfect.
It's a mixed bag.
So are there any questions for Dr. Parmod?
Dr. Parmod?
Yeah, sure.
Great presentation, and thank you for going over the literature for us. I have a question, and I think that's like very important question, that what do you recommend about the cats, and specifically for these patients? So I remember talking to this patient that is coming from his cat, and he was so shocked and like so sad. He was not sad about his own endocarditis, but that thinking that what is he going to do about his cat? Now, his questions are, can I keep the cat in the house, but just not let him be careful about scratches? Or do I have to get rid of cats forever? Or is it just a period of, like, I felt like, let's have a conversation, and his wife will come always and he'll tell him, make sure you tell the patient we have to get rid of the cats. So wife will always emphasize that, you know? So I just feel like, what are your thoughts about it?
Yeah, it's a great question. And coming back to this patient, I actually did forget to mention it. So he is back to demanding wanting his cat back. And the last conversation I saw with the infectious disease doctors was that since he had been treated appropriately for the Bartonella, that it may be safe for him to have the cat. Now, I have my own reservations on that. Unless you can keep the cat free from, because her note or the ID note says, as long as the cat does not have Bartonella. And I'm like, how are they going to know if the cat has Bartonella? So my thought is that if you can keep the cat flea-free and clear from having a transmission, maybe, but I would be really hesitant, especially with this gentleman having a prosthetic valve as well as a prosthetic graft, that he would be at risk for another infection.
That's interesting. So that's another question maybe for veterinarian, that can you diagnose Bartonella and treat Bartonella in the cat?
So interestingly, I did look at some veterinary literature just out of curiosity, and Bartonella does not cause a lot of major infections in cats. They tend to get, they tend to get by with very mild or no clinical features at all. I mean, there are some cases where they do cause significant infection, and they do treat them like we treat humans. But the cats getting sick are rare.
But can you decolonize them? Like they are colonized?
I don't know. I didn't actually look to see if there was anything in the literature for decolonization for cats. I guess
Let's put some doxycycline in their water.
Yeah, I mean, the problem is you would have to stop the cat from ever going outside too. I mean, it's going to pick up fleas or
I'm just trying to be pro-cat. I
Me
share your
too.
feelings.
I mean, trust me, this patient like really wants his cat back. So, you know, I kind of looked into it because I was not really in accordance with the ID doc that having his cat back was the best option, but we'll have
Thank
to wait and
you.
see.
Thank you.
But no, thank you. That was a really good question.
Thank you, Dr. Shah. Are there any other questions, cat related or not? Dr. Ruchi, I don't know if you have a question or you are coming to take the stage back.
No, I just wanted to thank Dr. Parmod for such an interesting and informative presentation. And if there are no questions, I put the link for the interview room in the chat so I can, the candidates can click on that. Dr. Phillips, did you have a question?
Oh, no, thanks.
Okay.
But great presentation. I enjoyed it.
Thank you.
Perfect.
Happy
Thank
Halloween,
you.
everyone.
Yeah, have a safe and nice Halloween, everyone. Have a great weekend. And again, I hope you will have a great rest of the day for the candidates. And I hope that your day has been very fruitful and you have gotten to know our program the way you want it. Thanks, everyone. Have a great weekend.
Thank you.